Hey everyone, Dr. Shad here and welcome to the Prosthodontics video series. This is the coolest specialty in dentistry, but as a prosthodontist, of course I'm a bit biased. But nevertheless, I'm really excited to teach you guys this topic, and we're kicking things off with a banger, Edentulous anatomy. In this video, I'll be going over the maxillary and mandibular edentulous anatomy, and I'll also point out the high yield points that you should remember for the exam. Okay, let's get into it. We'll start off by identifying some important maxillary edentulous structures. The first being the incisive papilla, which is an oval-shaped elevation located on the roof of the mouth. On either side of the incisive papilla is the palatine rugae, and running down between the rugae is the median palatal suture, which joins the left and right maxilla. The residual ridge refers to the size and shape of the alveolar ridge after removal of the natural dentition and is an important area of support for the maxillary denture. More on that later. Next, we have the labial frenum, which is a piece of connective tissue that is located at the very front of the mouth and attaches the lips to the gums. On either side of the labial frenum is the buccal frenum, which, you guessed it, attaches the gums to the inner cheek. Now, the labial vestibule is located between the labial frenum and the buccal frenum. Then we have the tuberosity, which is a rounded bony protrusion posterior to the residual ridge that can interfere with the mandibular denture if it grows significantly. The hamular notch, on the other hand, approximates the posterior extension of the maxillary denture. And connecting the buccal frenum to the hamular notch, we have the buccal vestibule. Next, we have the vibrating line, which marks the junction between the hard palate and the soft palate and can be identified by having the patient repeatedly say ah. Now, the soft palate area right behind the vibrating line is composed of non-keratinized tissue, and we also have some minor salivary glands here. Sometimes a portion of the soft palate is referred to as the posterior palatal seal area, as we rely on the compressibility of the tissue here to give us our denture seal. Next, we have the fovea palatinae, which are two small pits right adjacent to the vibrating line. There are also several important structures on the maxillary denture itself that are created during the complete denture fabrication process. The labial flange is the portion of the denture that occupies the labial vestibule, and the buccal flange is the portion that occupies the buccal vestibule. And finally, we have the Distrobuccal Flange. Together, the flanges provide a peripheral seal and help stabilize the maxillary denture. Now that we've gone over the maxillary edentulous structures, I'm going to emphasize the high yield points that you guys should remember. First, the primary stress-bearing areas of the maxillary denture are the hard palate and the alveolar ridge. And this should make sense to you. The hard palate is very resorption resistant, making it able to withstand load-bearing stress. As for the residual ridge, although not as resorption resistant as the palate, it is the only other bone-supported region besides the hard palate that is horizontal, which allows it to withstand the forces put on it by the denture. Second point I want you guys to remember is that a deep buccal vestibule provides greater surface area, retention, and stability. So when the vestibule is properly filled with the denture flange, the maxillary denture will resist vertical and horizontal dislodgement. Next point concerns the coronoid process, which defines the distal most extension of the maxillary denture, otherwise known as the Distrobuccal Flange area, and it does so during the border molding process. Now, if this isn't done properly and we end up with a Distrobuccal Flange that is too thick or too wide, let's say, we can have interferences with the patient's mandibular movements. In other words, when the patient moves side to side, the coronoid process is going to hit the bulky Distrobuccal flange, causing soreness, mandibular restriction, or even dislodgement of the denture. Next, we have the all-important posterior palatal seal area. To further prevent dislodgement of the denture, the posterior palatal seal resists horizontal and lateral forces acting on the maxillary denture as it terminates on soft, resilient tissue. Thus, the posterior palatal seal provides retention and stability and is determined by tissue resilience. Okay, another point to remember is that the incisive papilla is the anatomical structure that is least likely to change and resorb after full mouth extraction. And this makes sense because the incisive papilla isn't a bone-supported region. It contains nerves, arteries, and veins, so it's resistant to resorption. The last point I want you guys to remember concerns the maxillary tuberosity. When it comes to the patient's anatomy, the maxillary tuberosity can sometimes come into contact with the retromolar pad. When this happens, it needs to be surgically reduced prior to the denture fabrication process. Alright guys, enough of the maxilla. Now let's move on to identifying some important mandibular edentulous structures. Like the maxilla, here we have the labial and buccal frenum, But in the mandible, we also have a third frenum called the lingual frenum, which connects the bottom of the tongue to the floor of the mouth. The mandibular denture also has labial and buccal flanges that support the denture. The residual ridge, shown here in green, is also present, and at the distal ends of the residual ridge are the retromolar pads, which are triangular soft pads of tissue, 2/3 of which the denture base should extend over. Bound medially by the residual ridge and distally by the retromolar pads are the buccal shelves, which are just bony landmarks between the alveolar ridge and the external oblique line. And lastly, we have the lingual flange. Okay, now let's emphasize the high yield points that you guys should remember, starting with primary stress-bearing areas, which are the buccal shelves and the retromolar pads. The retromolar pad, similar to the hard palate, is an area that is resistant to resorption and is therefore a consistent and stable landmark throughout a patient's edentulous timeline. The buccal shelf, on the other hand, is also very resorption resistant, and it's composed of dense cortical bone, allowing it to best withstand stress-bearing loads. Now that you know why the retromolar pads are so important, this next point makes a whole lot of sense. In order to ensure our denture can rest on the retromolar pads, we need to ensure we capture it during our impression, and that it's nicely transferred over to the cast that will be used to fabricate the denture. And as I mentioned before, if fabricated correctly, the mandibular denture will cover 2/3 of the height of the retromolar pads. This will add a great deal of stability and support to the denture. Last point I want to mention, guys, is about the mylohyoid muscle, which border molds the lingual flange, and this is because the mylohyoid functions to elevate the tongue and the floor of the mouth during swallowing. Therefore, the depth and contour of the denture's lingual flange is determined by the position of the mylohyoid muscle. In turn, it would make sense that if a patient's mylohyoid is rigid or unable to fully relax, the denture would then have a shorter lingual flange. Alright guys, time to take what we just learned and do some practice problems together. Which of the following describes the anatomy posterior to the maxillary complete denture border? Remember guys, this is referring to the soft palate. So take a minute or pause the video if you need, but the answer is B, non-keratinized gingiva and minor salivary glands. Keratinized gingiva is typically non-displaceable, and we know this area of the mouth does not contain cancellous bone, so that would be incorrect as well. Alright guys, moving on to question number 2. Each structure affects border molding of the maxillary labial flange except one. Which is the exception? Again, pause the video if you need, but the answer is C, infraorbital rim. Now, even though we didn't directly discuss some of these structures, you should have been able to arrive at the answer pretty easily. We know that the zygomatic and orbicularis oris muscles are within the vicinity of the labial flange, as is the labial frenum. Therefore, during border molding, they will certainly have an impact on the labial flange. The only option that is kind of distant is the infraorbital rim. It's also a bony structure, which would have been another clue pointing to it being the answer. Alright, let's move on to example question number 3. Which reference point on the retromolar pad is used when determining the placement of the occlusal plane? Again, pause the video if you need, but the answer is C, 2/3 of the retromolar pad. I think I mentioned this a few times, so if you got it wrong, make sure you go back and watch the video. The retromolar pad is a stable clinical landmark because it's resistant to bone resorption and its position remains constant even after teeth are extracted. So a denture base that covers up to 2/3 of the height of the retromolar pads adds stability by creating an additional plane to resist dislodgement. Alright guys, here are our summary points, and that is it for this video. Thanks for watching, and I'll see you next time.